George, thank you for the presentation. Next up, we have Neil Goldfarb, who is the Executive Director of the Greater Philadelphia Business Coalition on Health.
Great. Okay, good. Hi. So I'm here to tell you a little bit about the Greater Philadelphia Business Coalition on Health and the Health of Philadelphia. And then presumably the reason I was invited here is to talk a little bit about some of the community health initiatives that we've undertaken in our first 2 years of our existence. And I'll conclude with some of my thoughts about facilitators and barriers to engaging businesses in community health. So I launched this coalition in around 2.5 years ago. I'd spent 12 years at the Jefferson School of Population Health as Associate Dean for Research. And many years ago, I got linked up with Andy Weber and NBCH, the National Business Coalition on Health, and really came to appreciate the role of business coalitions in driving improvements in healthcare. So I left Jefferson 2.5 years ago with the goal of trying to start a coalition in Philadelphia where one had never existed. And people say to me, why wasn't there a coalition in Philadelphia? It's because nobody was stupid enough to try before me. We currently have 36 employer members. Most of those are pretty big national companies. We do have some local law firms, but we have a lot of national companies. So locally we represent, now it's closer to 500,000 covered lives and more than 1 million lives nationally. We're a employer coalition, but we're multi-stakeholder in that we have a category of membership called affiliates, which allows health plans, pharmaceutical companies, benefits consultants, and other organizations to join us at the table for discussions. We think the solution is multi-stakeholder, but we never want to lose sight of the fact that my job is to represent business at that table. We cover a pretty large territory geographically. Philadelphia, if you're not familiar with it, okay. It hasn't been 10 minutes already, has it? Philadelphia is that a much more affordable suburb down the road from Manhattan. But there's the Philadelphia 5-county area, Philadelphia County, inner city largely, and 4 surrounding counties that are more wealthy, and I'll show you some data in a second. Plus, southern Jersey has 3 counties that really are suburbs of Philadelphia, and then we also included northern Delaware. Here's our mission: to keep employees healthy and productive in the workplace, but also to recognize that no matter how well you do employee wellness, people are going to need health care. And we specifically set our mission this way because, the employer wellness movement, talking to employers, I think a lot of them had the impression if we can only keep our employees well, we won't have this big healthcare cost mess and this healthcare quality mess. And let's just keep them well till they get to Medicare, and then it's the government's problem. And so we had to make very clear, so much of the money you're spending on healthcare is waste, but wellness is only going to do so much. You have to really address the fundamental problems in healthcare quality, safety, access, and cost. A few initiatives that I wanted to spotlight today. This is not an exhaustive list of what we're working on, but 3 initiatives that we're working on that I think fit with today's theme. Here's some data from America's Health Rankings that just shows Pennsylvania is very much in the middle of the pack. But when you look at county health rankings, you'll see that we have disparities across the Philadelphia 5-county area. Philadelphia County is actually ranked dead last in the state of Pennsylvania, and particularly obesity, smoking, and other population health issues are of significant concern. So here's the Philadelphia food pyramid. I wanted to make sure, when you're speaking almost last on a long day program, you know that almost everything of value will already have been said. So I knew this slide would not already have been covered. But here's our food pyramid. I don't know if you can all make out under meats there, that's scrapple at the bottom, and Taylor pork roll. But here's our superfood, which has all 4 food groups in it. And, when people think about Philadelphia, this is what they think about, right? You're all salivating, right? I can see that. Okay, so these are the problems we have to deal with as a community. And a couple of years ago, we were approached by the pharmaceutical company Sanofi which was interested in taking the model that David Kindig and others have developed, and that's been published by the IOM, in terms of those three intersecting circles. And how can we start to address obesity as a major problem in the Philadelphia region with different interventions in each of those areas and bring all the stakeholders together into that sort of center section of the Venn diagram? So we created this thing called the Philadelphia Health Initiative that has three parts to it. One is at the community level, we started with trying to disseminate the Stop Obesity Alliance weigh-in guide, which is about, if you've never seen it, it's a great resource about how parents can have discussions with children about healthy weight. At the academic center or health system side, we have a couple of health systems, and definitely hitting some stumbling blocks getting health systems to cooperate with each other, but trying to get health centers to lead by example for their own workforce, for the patients they serve, and for the communities they serve. And then I'm going to talk about our Diabetes Learning Collaborative, which is in the workplace. So we decided to try to get employers focused on preventing diabetes by recognizing early risk, particularly obesity, and dealing with it, starting within the walls of the business, the workplace itself, and develop this idea for creating a learning collaborative among employers in the region, where the employers would share data on obesity, on practices of what they were doing, their benefit designs, try to learn from each other. We would bring in other outside speakers and get them thinking about new ways to address obesity. They would each develop their own customized action plan for more aggressively dealing with obesity in the workplace. And then they would participate in monthly meetings, either telephonically or in person. So we put out this call for the Learning Collaborative with the hopes, fingers crossed, that 5 of our, at the time it was around 20 employer members would agree to participate. We ended up with 11 employers saying, yeah, this makes sense to us and we'll do it. And I'm happy to say that those 11 employers are still 1 year later engaged. Are they all doing as much as I think they could be doing? No. But are they coming to the table? Are they measuring? Are they trying to do things? Yes. So we continue to meet. 10 of the employers have submitted their customized action plans, and we're trying to help them implement it. And one of the things we're doing that sort of spotlights what's the value of a coalition as opposed to every employer doing things alone is we've been promoting the CDC's diabetes prevention program as an evidence-based approach to addressing diabetes risk and overweight in particular, obesity in particular. And one of the things we learned is that even when employers want to put in the DPP, which most of our employers want to do, there are barriers at the insurer level. How are we going to credential these providers? How are we going to process the claims? And why should every employer have to fight that battle individually? That's why we need coalitions to carry that standard forward. So this is what we're doing in that area. Another area is coming out of the gate. When we first announced that we were forming a coalition, we were approached by the Philadelphia Department of Public Health. I give the leadership of that department a lot of credit for recognizing that an important part of their community health efforts had to take place in workplaces. And they came to me immediately and said, we hear you're starting a coalition. We've been trying to get employers engaged. We can't get employers engaged, particularly on an individual level. Can you help us by, let's do this through the coalition? And we said, sure, we'll certainly try. So with some CDC funding, the Philadelphia Department of Health funded us for a small piece of that. Their goals were to address smoking cessation, hypertension, lipidemia, and later diabetes. And we decided to focus on how can employers change their benefit designs to to lessen obstacles to getting the right products at the right times. So we put out recommendations for how could benefit designs be modified for smoking cessation, including things like covering nicotine replacement therapy, not limiting the number of quit attempts that you pay for. Hyperlipidemia, hypertension, and diabetes much more focused on zero copays for generics, zero copays or very low copays for brand name drugs. And if anybody's interested, you can email me. I'll send you the actual recommendations. The employers all got very excited about this stuff. We still haven't been able to get the employers to move from excitement to implementation. And we're still working on what does it take to move this up on the employer's priority list so that they'll actually take the time to implement the value-based designs. They like the concept. They're not convinced that they can do it, or it's not at the top of their list. The third project I want to spotlight is our work in trying to ourselves, as the business community, convene a multi-stakeholder group to work on a community health issue. And we got some seed funding through the National Business Coalition on Health with funding from Robert Wood Johnson Foundation and United Health Foundation to do a community health planning project around reducing disparities in cancer screening rates. And as we worked on the project, we learned from the community it couldn't just be about cancer screening rates. The bigger disparities came up in treatment. People getting screening and then not being able to access care afterwards. So we expanded the scope of the project. We've developed a plan. We're looking currently for funding to do pilot testing of the plan. And the plan in a nutshell is having central resources that local specific communities can draw upon to help them implement actions that make sense for their community. And it sort of reinforces the idea, one size does not fit all. You can't do community health planning at the aggregate level and say this is what's going to work for the Philadelphia community or the Iowa community or anything else. Within Philadelphia, we have 30 different communities, neighborhoods, ethnic groups, other self-defined communities, and they all have different issues. Okay, so what have I learned from all of this in my remaining minute? Some of the facilitators. First of all, having leadership. We've heard a lot about that today. Leadership that gets it and is committed to trying to make it happen. Having a public health authority that got it as well and wanted to work with the business community. Now, we're trying to figure out, do any of the other county health authorities beyond Philadelphia, because I mentioned we're in 9 different counties, do any of them have any interest in this? I'll let you know at some point in the future. Having champions among our own members who get it is really important. Having seed funding from outside sources has helped because basically the employers in the coalition will let me do what I want to do as long as it's not costing them a lot of additional money. So if I can go out and say, I'm looking for some seed funding to support this disparities project and the business community is on board, the business community is on board. They're just not necessarily going to fund it at the outset. Having some large employers, including the public employers, and this gets to the idea again that national large corporations with workforces dispersed all over the country sometimes have a very difficult time singling out one community and addressing, they want to know, well, if I do this in Philadelphia, what am I going to do for my workers out in Dallas? That kind of approach. So we heard that this morning too. Academic programs, there are a lot of academic programs in Philadelphia. When I was an undergrad, there were no public health programs in Philadelphia. I think there are 6 now. So we draw upon academic resources. And I think most importantly on that plus side, we are starting to see employers who get it. We're starting to see that employers recognize that, as was said this morning, employees go home at the end of the day to unhealthy communities, and we need to address the community health aspect, not just the workplace health aspect. The barriers, a couple of barriers there. We talked about a few of those already. One that I really wanted to emphasize here that hasn't been raised explicitly today is the disconnect between HR, sort of that internal, who's taking care of the population of workers, versus the people who are dealing with these sort of community health programs from businesses are community relations, public relations kind of people. My experience in talking to my members is the HR people don't know who those community relations people are and what they're working on. And we just had a recent example of one of our large members announced a major influx of cash for addressing obesity in Philadelphia, that they didn't even know they were a member of a coalition that was already dealing with obesity in Philadelphia. So it's great to have that cash, but there was just this big disconnect within these large corporations. And you can read those others. I think I've hit my time mark. So thanks.